Hey everyone, Dr. Robinson here. We are going to discuss the chapter. It's on trauma and stressor related disorders. It's chapter 7, beginning on page 265 in your DSM. Again, I'm going to make my recording brief. Should be less than 15 minutes because that appears to be what I can record. And it's just going to sort of be brief and cursory. A little introduction. Obviously, I want you to read the text and I want you to read this section of the DSM. I'm going to just sort of highlight a couple of things. Predominantly, we're going to focus mostly on PTSD, and then we're going to talk about adjustment disorder a little bit. And you'll see why I want to make sure that we talk about that. So let's jump into trauma and stressor related disorders. Again, typically when we think about trauma and we think about disorders associated with trauma, usually what comes to mind is PTSD. And if we were in a classroom, I would actually ask you what comes to mind and assume you would give me that answer. But typically PTSD is the thing that comes to mind, so post-traumatic stress disorder. But there are other trauma-related disorders. And so starting off with some childhood disorders, your DSM goes into reactive attachment and then disinhibited social engagement disorder. And so we'll just sort of jump into those. And so remembering that these disorders, reactive attachment and disinhibited social engagement, and these are in children, and these are in children who have been neglected. So they've experienced some sort of trauma, they've experienced neglect, and those two things can be connected. So the neglect could be so severe or could be perceived and experienced in such a way that it is traumatic for the child. So in reactive attachment, and I've got my DSM here and I've got my notes, so that's kind of what I'm looking at. I've got actually like about 3 computers going, 2 computers and a tablet going right now, and then of course my DSM. So we're looking at children who are at least 9 months of age when you make this diagnosis, or if you're considering this diagnosis, they need to be developmentally at least 9 months of age. So not chronologically. And reactive attachment is described as children who are withdrawn and sort of disconnected in a way that they're not forming these appropriate attachments that they should be forming at their developmental age and stage. And so this cannot be explained by a diagnosis of on the autism spectrum or any other sort of developmental delay. This is best described because of this neglect and lack of attachment to a caregiver at that early age when it's needed. So basically, a lack of a parental figure or a caregiver emotionally responding to their cues, just sort of leaving them inconsistently with random people or alone, and doing so much so that this does cause, in fact, trauma to the individual, to the child. These two are quite sad to me. Having a young child, it's hard to sort of read about these and think about them. But know that this is different than maybe the difference in social appropriateness from someone, a child who is on the spectrum. This cannot be explained through a diagnosis on the spectrum. This is explained because of abuse and neglect. And again, they need to be at least 9 months of age developmentally, and this is diagnosed before 5 years of age. If you're looking at an individual who is 5 or older, you're probably looking at some different diagnosis. Let me think. What else do I want to? These children have compromised emotion regulation, so the inability just to display appropriate emotion, again, considering their developmental age. So making sure that you're referencing back to those sort of lifespan and developmental models when wanting to make this diagnosis. And just because a child may have experienced neglect from their caregiver and have experienced some sort of trauma in that way, doesn't necessarily mean that they're going to have this disorder. Again, human beings have too many variables to them to make those automatic assumptions. So know that knowing that a parent may have neglected or not had this sort of close attachment to their child doesn't necessarily automatically mean that the child is going to have this disorder. And again, differential diagnosis, you're talking about autism spectrum disorder, and then some intellectual developmental disorders, so some developmentally delayed disorders. Those are differential diagnosis, meaning that you need to rule those out before you assign this diagnosis. Disinhibited social engagement disorder. This is an interesting one. So this is when a child displays inappropriate behaviors towards strangers or individuals that maybe they should normally feel fearful of or weary of. The child does not, and so those normal, again, talking about sort of normal lifespan and developmental milestones or behaviors that children within that age range or developmental age should be experiencing, these children do not. So again, just as a result of neglect, as a result of constantly changing who the caregiver of this child is can result in this disorder. So no consistency in who is actually the caretaker of the child. So the child is hearing or receiving that there is no one main person to establish an attachment to and go to for safety. So if you think about a young child, when they're fearful or they're scared or they need reassurance, there's always one or two people, usually mom and dad, that they can go to and that they do go to. And so this individual never sort of established that. And so there's no close attachment, and they can go to anyone, or they can confide, feel comfortable. That's probably not the best way to describe it, but there's just an absence of finding that familiar safe place, and that anyone can be familiar and safe to this child or to these children. Again, needs to be at least developmentally 9 months old. And let's see, it can't be better explained by sort of cultural oddity. So we might think that the way that a culture rears its children is different or cold or aloof. That doesn't mean that they get this diagnosis. Or we may see a culture specific to disinhibited social engagement. We may see children in that culture be overly forward or not attached to their parent in a way that maybe we do as Americans, and that doesn't necessarily mean that they get this diagnosis. Prevalence for these, we're not 100% sure. We don't have super great data on it, but know that you need to make sure that you're ruling out for disinhibited social engagement. Make sure you're ruling out attention deficit hyperactivity disorder. That's the closest differential diagnosis. Moving on to post-traumatic stress disorder, and I'm looking at my time on my video recorder. I can't figure out why I can't record 15 minutes, but if I go beyond 15 minutes, I'm going to upload another video, and I hope you do watch it, even though it might be a little bit long. So post-traumatic stress disorder, like I said, we're going to spend a little bit of time on this. So I'm going to talk to you about it in terms of for 6 years of age or older, and then those that are below 6 years of age. So this is when an individual directly experiences, i.e. they physically experienced or they witnessed a traumatic event, or they were a part of this traumatic event. I mean, we're predominantly talking about big T traumatic events. That doesn't mean that little t traumas can't be equally as traumatizing, but when we're talking about diagnosing post-traumatic stress disorder, these are typically larger traumatic events. So directly, again, directly experiencing these events or witnessing these events, being a part of these events. So I worked with an individual who was at Columbine, and he didn't really necessarily wasn't right there. He didn't see everything, but he was at that school, and so he was a part of this event. And I would argue that he fit the bill for PTSD. So again. So in adults, the DSM goes into a great detail to lay out the criteria that apply for adults. And there's a lot. There's a lot to sort of ferret out and cipher through. Know that the disturbances or the criteria or the behaviors, it's a month past the event. Acute stress disorder is like right after the event, but if it's a month after, then we're talking about post-traumatic as opposed to acute. There are some specifiers when you're looking at the criteria, so make sure that you look at the specifiers. Depersonalization, so sort of feeling very attached of the individual outside of the individual, and then derealization. I guess that's best described as sort of dreamlike. And then delayed expression. This is when it's like 6 months after the event that the individual is starting to experience these the criteria that's outlined in the DSM. For children 6 years and younger, again, the DSM goes through and outlines the criteria very well. There's a lot to the criteria. Again, it's still more than a month away of the event, so the event has to have happened more than a month prior, or if it didn't, you're still talking about acute stress disorder. PTSD in children can look very different than what it can look like in adults, which is why they have the two separate categories and the two separate criteria. And so for example, and this is a little bit timely, I guess. I shared with you guys that I went through Hurricane Katrina, and in the aftermath, when we're looking at young children, and there's been a lot of studies done on this, it's been quite interesting. But when we look at young children who were young and maybe kindergarten age, first grade age, or even infants who went through Hurricane Katrina, they started developing what looked like ADD. A lot of children were being diagnosed with ADD or ADHD, and that sort of language was being thrown around. But when people really started dissecting it and really started pulling the pieces apart, the common theme was that they all experienced Hurricane Katrina as a very young child, and so they had these symptoms or these behaviors that looked quite different, and some of them fit more into the depression. Depression for children looks very different than depression for adults, but some of them fit in the criteria of depression, but then certainly some of them fit in the criteria for post-traumatic stress disorder for children. So be mindful that can look very different for adults and for children. The interesting thing about PTSD is that it can look different for different people. There are some individuals who have PTSD symptoms that are sort of very fear-based or emotionally laden responses that are rooted in fear. So just being very fearful, being very weary, being sort of isolated because of fear. And then some can be more related to mood, so being very withdrawn or anhedonic, depressed, seemingly depressed, sort of withdrawing and really not finding satisfaction in life. Anhedonia is not enjoying things that you once enjoyed. So that can be one presentation. Then another presentation can be reactive. So those arousal responses, very hypervigilant, just sensitive, or